Welcome to AETCM, the emergency medicine channel. A 93-year-old male presented to ER with complaints of vomiting, decreased oral intake and constipation since 2 days. On initial 10-second assessment, airway was patent, no pooling of secretions. BP, breathing, saturation was 96% in room air, respiratory rate was 20 per minute, air entry bilateral equal. Coming to circulation, BP was 70/40 millimeters of mercury and pulse rate was 110 per minute. At this point of time, we secured a 2 large bore IV cannula and IV fluid 1 pint RL was initiated. During the meantime, point of care ultrasound was done, which was showing an collapsing IVC and good LV. Coming to disability, GCS was 15/15, pupils equal and reacting to light. Coming to exposure, patient was afebrile. On reassessment, BP was 90/60 after 1 pint of RL, and so we have started on another IV fluid RL and under the NORAD coverage. Coming to adjuvants of primary survey, VBG showing pH of 7.337, potassium 4.1, sodium 133, calcium 1.16, lactate 10.6, creat 2.39 and bicarbonate of 24. CBC, we have done CBC CRP point of care, WBC showing 9,000, hemoglobin 15.1, hematocrit of 54, platelet 206, CRP was 84.5. ECG was showing a sinus tachycardia with a rate of 110. On repeat VBG after fluid resuscitation, lactate was from 10.6 dropped to 5.8. Coming to secondary survey.
So, from this much, what can you tell? What are you dealing with?
Patient, there's hypotension is hypovolemic, most probably hypovolemic.
Why you are saying hypovolemic?
Patient was having vomiting and decreased oral intake.
Okay, decreased oral intake and vomiting. But that is 10-second assessment as such. No, even without that 10-second assessment, can you say what type of shock you are dealing with? You told a lot of values and all, no?
Hypovolemic itself.
How can you tell?
Fluid, patient is fluid responsive.
Patient is fluid responsive is okay, but see, you are telling there is a, what was your VBG findings? pH was?
7.337.
7.337, normal, with a lactate of?
10.6.
10.6, with a bicarb of?
24.
What does it mean? What does it mean?
That is
It shows a hyperacute shock. This is a very short period shock. That is why even though lactate is at 10.9, it haven't affected the pH nor the bicarb, because body haven't got time to get adjusted to get corrected to that acidosis. So lactate is quite high because there is no perfusion happening. Okay. So now the question is, why that perfusion? What is your CBC CRP values?
CBC was 9,000, CRP 84.5.
Yes, but more than that, what is the hemoglobin level?
Hemoglobin 15.1 and hematocrit of 54.
Yeah, so you get a hemoglobin of 15 with a hematocrit of 54, shows hemo concentration. So now you know it's not a trauma case for hemorrhage to happen. So it is a volume contraction. Because of volume contraction, it's a hypovolemic shock, isn't it? So that's why even after just like 1 liter fluid bolus, your lactate has nearly halved, right? From 10 to
5.8.
5.8. Okay, so with that much you can say it is a volume contraction shock you are dealing with. Now, why that volume contraction happened, you can come in secondary survey. Okay, now my question will be, why did you start the patient on noradrenaline?
Since we have done point of care ultrasound, good LV, we are considering the age of the patient. We don't want to push more fluids.
Correct. Be confident in saying that. What is the age of the patient?
93.
Yes, it's a 93-year-old patient. So you really don't know what is the cardiac status of the patient. A fluid overload doesn't mean total body water content increase alone. It's the amount of fluid that is injected into the vascular system within a short period of time. So if his heart cannot manage that much fast rehydration, patient can go into cardiac failure. Okay, so you can very confidently say we identified, we are given the first 1 liter bolus Along with that, we did a point of care ultrasound, as you told. And so, why? Because you want to assess the IVC to see whether IVC is collapsible, whether the patient is fluid responsive, and in the meanwhile, you have eyeballed the LV whether it is contracting good or not, or whether there is RWA. So, you are ruled out a cardiac component, and you are saying it's a fluid responsive. But more than 1 liter, when you want to give at 93 years, all guideline will tell you to give 20 ml per kg. So that is correct. You can give 20 ml per kg, but why not give it over a period of time? Especially since your repeat VBG showing an improvement, you know that it is fluid responsive. So you started a low amount of noradrenaline to make sure the hypotension doesn't worsen, and over time give fluids and decrease the noradrenaline, isn't it? Don't be confused with that. Be confident in answering.
Coming to secondary survey, a 93-year-old male, known case of hypertension, diabetes, dyslipidemia, BPH, presented to ER with complaints of vomiting, which was multiple episodes in 2 days. It was also associated with constipation and decreased oral intake, and had complaints of dizziness while getting up from the bed. And he also gives history of vomiting out green color vomiters few hours back before reaching the hospital. There was gradually progressing abdominal distension with mild colicky abdominal pain. There was no history of any fever, decreased urine output, any shortness of breath, or any past history of any surgeries. On examination, patient was conscious oriented. There was no palorectal cyanosis clubbing lymphadenopathy. Patient looked dehydrated with a dry tongue. Per abdomen, on inspection, it was distended, no scars, no visible peristalsis. On palpation, it was non-tender, no guarding or rigidity, and auscultation bowel sounds were sluggish. So we had done an RT incision was done from the ER in view of distended abdomen and suspecting an abdominal intestinal obstruction. So 1000 ml of bilious fluid was drained, and we did a USG abdomen pelvis bedside. So it shows dilated bowel loops in right iliac fossa with a to and fro peristalsis, which is suggestive of intestinal obstruction. We had also started on injection cephalosporin sulbactam combination 2 gram. And we had directly done a CT abdomen. We didn't do a CT because creat was in the VBG was 2.39. So CT is showing features of mechanical bowel obstruction with a transition point at proximal ileum, where bowel is seen to take an acute turn. No features of mass lesion, bowel wall thickening, or mesenteric fat stranding noted at the site.
Okay. So, so it's a clear-cut intestinal obstruction case. Your history is suggestive of intestinal obstruction. You have bilious vomiting, and you are diagnosed with the insertion of RT. RT is draining bile fluid. So clearly it's an intestinal obstruction. Okay, so that much is fine. Here, if intestinal obstruction case comes, what are the most common symptoms a patient will have?
Vomiting, abdominal distension,
Most common symptoms. So we'll start from the commonest, right?
Colicky abdominal pain.
Colicky abdominal pain.
Constipation.
Yeah. So constipation, then
vomiting.
Vomiting, but vomiting is more likely to be with proximal intestinal obstructions, like small bowel obstructions. Like you have small bowel obstruction and colonic bowel obstruction. So small bowel obstructions are predominantly associated with the vomiting because less area to contain the pressure and fluids. But colon can distend significantly. So colonic obstructions rarely presents with vomiting, but can present. Okay, then what else? Obstipation, correct. Obstipation can be there. But the problem with obstipation is there can be patients who can say, I have passed stools, mainly because if you have a proximal obstruction, your distal bowel is still having feces, and that can always get evacuated. So patient may not tell you obstipation as such. Once the entire bowel, distal bowel is collapsed, then only patient will develop obstipation features. This is why certain intestinal obstruction patients will tell, today morning also I passed stools. Okay, so obstipation is not a very classical history that you can depend on. If it is there, good. If it's not there, that doesn't mean that patient doesn't have intestinal obstruction. Okay, what else? What is this?
Abdominal
Distension. So abdominal distension, which is followed by abdominal pain, colicky abdominal pain, followed by constipation followed by distension followed by colic abdominal pain followed by vomiting. This is how the presentation is usually. Distension is usually associated with colonic obstructions because colon distends out, balloons out. So distension will be there, and vomiting and pain is more with small intestine obstruction. Okay, so this is history wise. What other history is important? What other history you need to ask the patients?
Any past history of surgeries?
Past history of surgeries because you are suspecting adhesions.
Adhesions.
Okay, then
Any weight loss, progressing symptoms to rule out any malignancies?
a malignancy. So when you say weight loss, it's not only weight loss. What you have to ask about is any chronic bowel habit changes, any multiple episodes of loose stools followed by chronic constipation history. That history you need to ask, and if that is associated with weight loss, you can think about malignancy. What else?
Any drugs?
Drugs. That's very important because some patients may not have mechanical obstruction. It can be due to hypokalemia. So you need to get a drug history to see whether patient has any furosemide which can cause hypokalemia induced paralytic ileus. Okay. What else? What other history do you want to ask here? What else can cause intestinal obstruction like features? Does any intra-abdominal infection cause peritonitis? Means intra-abdominal infection cause paralytic ileus? Intra-abdominal infections with peritonitis will cause local paralytic ileus. Patient can present with intestinal obstruction like symptoms. So any localized peritonitis features should be looked into. So coming to then, when we come into examination, what are the examination features that you are looking into?
Abdominal distension.
Abdominal distension, tympanic, right? So tympanic abdominal distension, then
any visible peristalsis.
Visible peristalsis, but in adults it's very difficult to get a visible peristalsis, right? Because most of the adults have a good fatty abdomen, so very unlikely to see it. But you have to look for it. What else?
Bowel sounds and tenderness.
Tenderness. So you have to look for any local tenderness. If localized tenderness is there, what will you suspect?
Peritonitis.
Peritonitis. And if you have peritonitis, what are the things that you will consider?
Perforation.
Only is perforation, but yes, when perforation initially starts, it will be localized peritonitis. What will be a perforation history be like? Can you suspect perforation in history?
Colic abdominal pain changing to continuous pain.
Yeah, changing to continuous pain. That is true. Fever history. But fine. Fever history.
Not moving.
Huh? Following straining. Hypotension. All this is correct only. But as you told, fever, your hypotension, both are features of peritonitis, that is features of infection due to bowel content in the peritoneal. A rebound tenderness is a feature of peritonitis itself. Peritoneal irritation is what you are getting. But the history wise, very important will be, patient will say, like patient has intestinal obstruction induced pain, no? Patient will say, I was having constant, like what you were saying, colicky pain, suddenly I had a relief of pain, followed by severe worsening of pain. So you told continuous pain, that is correct, but continuous pain is basically severe increase in severity because it causes peritonitis. So initial perforation will relieve the intraluminal pressure. So patient will suddenly have that colicky abdominal pain will go away. So patient will feel a bit better before the peritonitis starts. Once peritonitis starts, patient will say that I have worsening of pain which is now continuous. So that is the history wise that you will suspect. Perforation. What else? What can intestinal obstruction cause to the bowel? Ischemia. Bowel ischemia can develop. So bowel ischemia can cause local peritonitis-like features, but not peritonitis, peritoneal irritation. So localized tenderness can be due to bowel ischemia or can be due to perforation. So any abdominal guarding rigidity is there or any localized tenderness is there, we should go for higher level radio imaging. Okay. Now with this history and examination finding, you want to confirm, right? How can you confirm intestinal obstruction?
X-ray, rectal abdomen, we can take.
Yeah. So you need a radiological imaging to confirm intestinal obstruction. There is no doubt about that. So the main thing or most commonest investigation is
X-ray.
X-ray erect abdomen. So what if this patient is paraplegic, or what if the patient is post CVA, cannot stand alone, or cannot stand even with support, they can't. What will you do?
X-ray supine and lateral decubitus.
You take X-ray supine for baseline bowel status, and you put the patient on a laterally placed position so that air
Fluid level can.
air fluid level will form over the lateral upper part, isn't it? So lateral decubitus X-ray can be used to take. But when you take specificity and sensitivity, X-ray lateral decubitus supine has much less sensitivity and specificity in comparison to a erect abdomen. So is erect abdomen always diagnostic of intestinal obstruction? What is a gold standard for intestinal obstruction investigation?
CVCT.
It's a CCT. Contrast enhanced CT abdomen is the gold standard. It has both sensitivity and specificity of more than 90%. Okay. So if you have a patient whom you are clinically sure of intestinal obstruction, it's better to go for a contrast enhanced CT rather than go for X-ray abdomen erect. But this thing depends on your center. If you are a tertiary center where you can treat the patient's intestinal obstruction, it makes sense to do a CCT there, because you get diagnostic and therapeutic decisions based on the CT. But if it is not commonly associated, or if you do not have the center capacity to treat it, it's better to take a CT abdomen erect, X-ray abdomen erect to diagnose. Because when we talk, we have to talk both about what can be done and what is required. Okay. Now, why CT is preferred over X-ray? What are the additional information you get?
Site. You can.
Yes, you get basically intraluminal intestinal obstruction. First of all, you get whether it is a actual intestinal obstruction or pseudo obstruction. Is it? That's the first cutoff, is whether it's actual mechanical obstruction or pseudo obstruction. So what is pseudo obstruction? Yeah, so paralytic ileus is a kind of pseudo obstruction. So how do you know in CT? So if it is a colonic pseudo obstruction, the colon can be dilated. So there is like colonic diameter is there, no? So as colon dilates, your colonic diameter increases, but your cecal diameter doesn't increase that much. So if your cecal diameter is lesser than your colonic diameter, most probably you are dealing with a pseudo obstruction rather than a mechanical obstruction. If mechanical obstruction, the pressure is extended uniformly. So anything proximal will be equally dilated. So cecum will also be dilated. So colonic dilation more than 8 centimeter is what we look for the diameter size as such. So first is true versus false obstruction. Second is, if it is true obstruction, you get to know site of obstruction. So is it intraluminal or is it intrinsic, that is bowel wall based, or is it extrinsic causing compression? So because based on that your treatment modality changes, right? Like intraluminal, you are looking for resections, you are looking for operative laparoscopy or open laparotomy you are looking for. If it is extrinsic, most probably it is adhesion induced. The surgeon may be able to do it in laparoscopy alone. You may not have to laparotomy the patient. And if it is intrinsic, there is nothing emergency there. You have to go for a diagnostic modality, either with a colonoscopy or endoscopy, get a biopsy done, or a CT guided biopsy to identify whether it's a mass or lymphoma or what is the intrinsic problem there, isn't it? So CT gives these decision points. Then
Any perforation?
yeah, contained perforations will not be missed. X-rays and ultrasounds may tell you there is intestinal obstruction, but if there's a contained perforation, it can very easily be missed. CT will clearly show a contained perforation. So these additional informations are available in CT. So if you have a if it is possible to go for CT, it's always better to go see CT. Okay, but we went for CT abdomen plain here. Why?
Creat was 2.39.
So because creat was 2.6, elderly age group, we didn't want to go for a contrast enhanced study. Okay. What can be one reason for the renal failure in this patient?
Pre-renal.
Most probably it will be pre-renal because he was so dehydrated, his creatinine levels might have been elevated. But you need to treat and see whether it's improving before you go for contrast. Okay. Now, what are the diagnostic points to say intestinal obstruction in CT?
Transition point.
Yeah, as you told in ultrasound, there is a to and fro peristaltic area. That's basically the transition point. So, in CT, you can see the transition point with proximal bowel dilation and distal bowel collapse. That's how you say there is a intestinal obstruction. Fine. So, our diagnostic modality is over. What else? What other investigations do you want to send?
Blood routines. You can say.
Tell.
Blood routine in the
It's not like CT is done, intestinal obstruction, go home, right?
The total WBC count.
Yeah, you want to rule out sepsis. Intestinal obstruction can progress towards intra-abdominal infections. It can be contained infection in the bowel or it can be peritonitis. So you need a sepsis workup, isn't it? Sepsis workups include multi-organ failures also. So LFTs, RFTs, total counts, CRP. Then you want Pyalticinius.
Potassium. Electrolytes.
You want the potassium levels, electrolytes, especially potassium levels you want. And these patients, the patients that you have told is decreased oral intake with vomiting, patient can have subacute intestinal obstruction, can have loose stools. So these patients can also have hyponatremia, isn't it? So those values you require. What else? Anything else you want? And then that's blood routines are okay. Now coming to management. How do you manage these patients? Intestinal obstruction, not dehydration, intestinal obstruction.
Keep the patient NPO.
NPO.
Then hydrate by IV fluids.
Okay.
Antibiotics.
Okay.
Antibiotics.
Before that, what you did? Decompress. Decompress. What you did? Decompress. So NPO, decompress. In decompress, you have to make sure that patient is placed on a erect position because intestinal relief of pressure can be drastic, causing patient to vomit and aspirate. So always better to make the patient sit up and put a raised shoe rather than place him down, supine position. Okay, so decompression, gastric decompression, continuous aspiration of RT, NPO, then you start rehydrating the patient, then antibiotic. What is the ideal antibiotic here? You have started magnets, right? Sulfarazone sulbactam, right? What is the ideal antibiotic? What do you want to cover? What do you want to cover?
Gram negative and if
Gram
there is
negative.
perforation, anaerobic also.
Okay, so you want a gram negative coverage. You want a E. coli coverage. That's what is there in your intestine. That coverage you should give. And if you want a extra coverage, a anaerobic coverage will not be bad. That's what you want. So what is your drug of choice here?
Cephalosporin.
Actually fluoroquinolones, but since intestinal obstruction patients, if they are in shock or sepsis or ongoing infection, we usually start second generation cephalosporins or third generation cephalosporins. So at least a fluoroquinolones to a ceftriaxone is the range in which you need to give. You can always give higher, but not necessarily. And what do you give for anaerobic coverage? What is the drug of choice?
Metronidazole.
Metronidazole, because GI availability is better, penetration better, you give metronidazole. So antibiotic you started. What else?
Electrolyte correction. If
Electrolyte correction as such. Okay. Okay. So what if this patient, so this is broadly what you are going to manage, then you are going to call up the surgeon for admission and further management. Now, one scenario, this patient on arrival to you is 70-40 BP, right? So, on arrival to you, it's 70-40 BP and patient is obtended. Okay, patient is obtended. Patient sensorium is low. Okay. Patient on assessment, patient is having tachypnea. Respiratory rate is around 40 per minute. Sensorium is decreased. Hypotension 70-40. Your primary adjuvant is showing same values except pH is 7.0 with bicarb of 10. How do you manage? What is the extra thing that you will do here? You want the GCS? 8 out of 50. You understood the question? No, question is very simple. Will you intubate or not is the question. That is the question. Question is, will you intubate or not? You have a obtended patient, GCS is 8 out of 15, who is having tachypnea with a rate of 40, which is basically a compensatory mechanism for already existing metabolic acidosis secondary to dehydration. Will you intubate the patient or not?
for airway placement.
Tell the answer. You are the doctor.
For airway secure.
You can't say for airway secure I will do and all. Will you intubate or not?
Yes.
This is the scenario.
Yes.
Will you intubate?
Considering the age of
Oh, that is too bad. That is too bad. Age should not be a decision factor for what you should do. Okay, that is up to the bystander to decide whether they want intubation or not. Your decision point should not matter. You should not intubate. You should try your level best not to intubate, because you have to understand that tachypnea is secondary to the metabolic acidosis, which is predominantly a lactic acidosis which you are dealing with, isn't it? So that lactic acidosis is due to volume compression that you are already proving. You intubate the patient, what is going to happen? You are going to sedate the patient, which is going to get rid of him from the sympathetic response. Already his BP is low, isn't it? So you need time to replenish the fluid. Before that, you try to intubate him. Without the sympathetic drive, he will crash. But much before that, the moment you give a paralytic agent for the patient, patient's GE junction is going to open and patient is going to vomit the entire abdominal content. And you are going to have an aspiration in your hand. So, if the patient's airway is patent, you first stabilize the patient with IV fluids, maintain the BP, bring up the BP, stabilize the BP, so that if you're going to intubate, you will have a stable vitals. And when you are intubating, you should expect, and once the vitals are stable, then whatever you are telling is correct, because patient sensorium is low. That sensorium low can be due to multiple things, but it can also be due to hypotension. So hypotension causing obtention of sensorium should be ruled out. So till that much correction of hypotension, you can wait. Because the only reason right now is what? Low GCS and airway protection. This is the only indication. So if your low GCS is reversible due to hypotension, you treat hypotension, patient should improve. But you treat hypotension, patient not improving, now you are kind of like, okay, you have an intestinal obstruction, there is a high possibility of aspiration, I like to secure the airway. But when you are going to secure the airway, you should expect aspiration because the paralytic agent is going to open the G junction. because it's not a normal patient. No, patient's gastric pressure is high, isn't it? So you should expect a aspiration. You should have a 4 years, but younger suction ready with you. Preferably, you may have to intubate blindly also because of ongoing gastric content. So that part, that will be the only decision making doubt you may have. Anything else?